Welcome, everybody, to our third day of the CCRN exam prep class. And today we're going to be covering GI and renal concepts. So for GI, I'm going to focus on GI bleeds, pancreatitis, liver failure, splenic rupture, and a high intra-abdominal pressure. There are some other topics in GI that you'll want to read about in your book. And then as for renal, we'll go through just the basics of kidney function. And then the three major topics of renal are the pre, intra, and post-renal failure. Again, there are some other topics that I'm not going to cover in this lecture, but you'll see in your book once you start to review. So GI, about 6% of the exam, similar to renal, in that there are only about 10 questions. So if you saw those two sections of topics, you can imagine about 2 questions per topic. Okay, so for upper GI bleed, the big thing is how do we correct the blood loss and then prevent further bleeding? Right? If they're hypovolemic from blood loss, then we want to start with isotonic fluids for that hypovolemic shock. We can give them blood, and then the obvious clotting factors in the form of FFP and platelets. Right? We can't always just correct with direct blood. We might have to add the addition of clotting factors. Vasopressin, if they are hypotensive, can constrict the arterial bed, especially in that GI tract, as it's not needed as much. And then the octreotide, we can give them octreotide drip, which is a drug that mimics an endogenous hormone in our body called somatostatin. Now, somatostatin is an inhibitory protein that ends up raising pH. Anytime we raise pH, we prevent potential ulcers from forming. That's why we give proton pump inhibitors as well to most ICU patients to avoid any kind of GI ulcers. It also slows down the digestive process, right? So if we're having potential bleeding, we want to avoid irritation of those areas if it's in the upper GI. And then we're going to slow or decrease the muscular tone in that GI tract. And by doing that, less blood will be sent to the GI tract. Another thing we can give is sorbitol. That's an osmotic laxative. And it's gonna help with flushing all that nitrogen waste out, that blood that turns into nitrogen waste. And if we're not certain if it's an upper or lower GI bleed, we can do an endoscopy. So we can stick a camera down and really discern where is it in the stomach or upper intestine. So that's going to be the first steps for treating an upper GI bleed. So big question is, what does the body normally do to get rid of blood in the GI system? So let's say you get a bloody nose and you get some blood in your stomach. What does the body normally do to break that down? And then what are some lab values we can check to confirm the severity or inability of this body's natural response to break down blood? This part is actually very fascinating, and how a liver can metabolize blood. Now, this also is a problem to think about in patients who have liver or renal failure. So normally, blood is metabolized and broken down into proteins and then into amino acids within the liver. And those amino acids are made up of components known as ammonia. We've all heard that before. And within the liver, 2 ammonia ions can be combined with carbon dioxide to form the ion urea. And urea is another common molecule we know, and that is what filters out in the kidneys. We can excrete it mostly in the kidneys, 90% of it. So when we measure, this is one of the lab values we can measure, the amount of urea in the blood that can indicate either our kidneys' inability to release or get rid of that urea, or it can indicate that we have a large amount of blood or potentially proteins being digested and metabolized down into ammonia and then urea. So for that reason, it's not always an indicator of kidney function, because there could be a lot of other things that indicate or change BUN. So when we go back to the idea of liver failure patients with an upper GI bleed, two big things we're looking for as far as lab values are our ammonia and our bilirubin, specifically our unconjugated bilirubin. And what we're looking for is high levels or concentration of these two molecules. So ammonia, the reason why it leads to encephalopathy and the reason why is actually patient dependent. After a certain point, we start not to care so much how far ammonia is elevated, as you know, the point to which my encephalopathy arises may be a lot lower or sooner than someone whose brain is potentially used to a lot of ammonia. So the brain, specifically astrocytes, utilize ammonia as a precursor to GABA. GABA is a molecule that we mimic with propofol to cause sedation, so it sort of mimics that sedative effect, encephalopathy. And then we also look at bilirubin. Bilirubin is a byproduct of heme. So as we break down blood and we get heme and it starts to be metabolized down into unconjugated bilirubin, if we have liver failure and we're not able to conjugate that and then excrete it in the bowels, then we're going to start to see high levels of bilirubin, which is more easily seen through the form of jaundice. So as these bilirubin levels rise in the blood and the liver is unable to conjugate them, they're going to have to go somewhere, and so the cell is going to take it up and store it, and that's where you start to see this jaundiced discoloration of the skin. Okay, so the next topic is esophageal varices. Now, esophageal varices, I want you to equivalate this to a rusted house water line. So a very important water line in your home has been damaged and to the point where it now has burst. And that's what we see with esophageal varices. We see a high pressure caused by liver cirrhosis. So for whatever reason, they have liver cirrhosis. It has caused a backup of pressure into the portal vein, hepatic portal vein, and backed up into which is fed by the GI venous drainage. And so as this GI venous drainage starts to form, we start to see varices. Like you'd see varicose veins in the calf. You see that in the esophagus. Now, there's a procedure that can be done to bypass this. If it's significant enough, the liver cirrhosis is significant enough and we can't perform a liver transplant, they can do a TIPS procedure, which we'll talk about later, but it essentially skips the liver vasculature and goes straight to the hepatic vein, which then dumps into the inferior vena cava. Now, the problem with this is there's no metabolism. If the liver is solely responsible for this and we pass it, then that can cause problems. So, as you see with our little figure here, that blood isn't going to make it back to the heart. If that varice bursts, it's going to start to dump in from that varice that's along the esophagus into the stomach, and to the point where if they throw up, it can come up and they can aspirate. So a lot of that blood can end up in the lung. And as a result of that blood going into the GI system, we have a lower preload, so we can have a lower cardiac output and hypotension from that. So something we can do to then stop this blood is known as a Blakemore tube. You've probably heard about these in nursing school or in the ICU. We don't use them as often because they're pretty risky, but what we end up doing is inserting this tube just like an NG tube, but usually orally. At this point, the patient's probably been intubated for airway protection. And what we'll do is inflate this esophageal balloon, this long balloon, along the esophagus to kind of clamp off those varices veins that have burst. And then we'll inflate this gastric balloon so that it can't be pulled out. And so it applies pressure as well to the bottom of those esophageal varices. Now, this is similar to the idea of a Foley. You know, if this balloon was in place and the patient was able to tug this, or if it was migrated out, it could end up occluding the airway. So a big thing they're going to try to test you on with this is, do you have scissors at the bedside? Because if this balloon ends up cutting off the airway, you know, you're not going to have enough time to deflate it, potentially. So what they want you to do is cut the air, let it all flow out, and pull out the tube. That's safer than causing potential airway occlusion and respiratory distress. All right, now the next topic we're going to talk about is pancreatitis. So just starting with the basics, what does the pancreas do? You can see here it secretes a lot more than just digestive enzymes. It secretes a lot of water. It can secrete some electrolytes and bicarb. And it all flows down through the pancreatic duct to help digest a lot of our intake. So secretion of these things are affected a lot by food, so change in glucose, as well as parasympathetic stimulation, right? We think sympathetic, we think fight or flight. And you can see what these different types of cells do. They may not necessarily ask you these on the exam, but it's just good to know, right? We talked about somatostatin earlier. So when we start to see pancreatitis, we think about it as a submarine, right? The pancreas normally shoots off these digestive enzymes that help break down everything just as it enters the upper GI. And in pancreatitis, something has caused these digestive enzymes to trigger early. And what that causes is an implosion. Basically, the pancreas starts to eat itself because all of these digestive enzymes are activated early. So as a result of this, we could see massive fluid loss and electrolyte loss because this pancreas is just pumping that water out into the interstitial space. And because of that, a lot of inflammatory mediators are activated, right, to try to swell and stop this, prevent potential infection. And so what you end up seeing from all this fluid and inflammation is a lot of atelectasis and pleural effusions, but more so on the left lower lobe of that lung, right? That's where your pancreas kind of sits, is more so on the left. But despite that, you're going to still hear bilateral crackles. And one of the things that is known with pancreatitis is that you end up losing some of these alveolar cells, these type A alveolar cells, which end up not being able to produce surfactant. So as the lung starts to lose a lot of this alveolar space, you get a lot of alveolar dead space, you start to develop ARDS, which if you watch the respiratory lecture, we'll talk a lot about. So the symptoms of this kind of self-implosion of the liver, of the pancreas, is you get this boring, this like awful abdominal pain. And it can radiate to all quadrants of the abdomen as well as the back, because you're just dispersing a lot of these acids out and throughout the body. You end up getting a tight abdomen because we talked about that inflammation and that massive fluid loss into the abdomen. So you're not going to hear as abdominal sounds as well. You're going to have a lot of nausea and vomiting and fever from all of this. Then what you end up seeing is a high white blood cell count, obviously, right? High amylase and lipase levels, as well as high blood sugar, because we're not able to administer this insulin to help recruit those glucose molecules into the cell. So what we call this is autodigestion. And as we start to autodigest a lot of this mesenteric fat, it starts to form these calcium salts. So it starts to utilize calcium, and as this fat is broken down, it starts to bind with this fat. And so we end up seeing hypoglycemia as a result. So in a later stage of pancreatitis, you can end up looking for these signs of low calcium. That's known as a Trousseau sign. So as you start to limit the blood flow to the arm through a blood pressure cuff, you can see that the tetany in these palmar flexion muscles. So the wrist is going to flex down towards the forearm, and you'll start to see a spasm because of that low calcium level. Another thing you can do, which is usually even a later sign, is tapping the face just below the ear. And what will end up happening is you'll start to see little twitching. And so that's a Schwarzschild sign. So these two signs you may see on the exam, they might mention it. And just know that's more so related to the hypocalcemia. This should be hypocalcemia associated with pancreatitis. Two other signs that you might see, and they will probably mention on the exam, are the Cullen and Gray-Turner sign. So you can see this man's abdomen is very tight, and potentially these digestive enzymes can break down blood vessels. So we call that hemorrhagic pancreatitis. And that blood is going to start to pool around the umbilicus as well as in the lower flank. It's just going to kind of trickle down there with gravity. So you'll see retroperitoneal and flank bruising. That's called the Gray-Turners. And then the Cullen sign around the umbilicus. So the big thing is, because we lose insulin, we want to start a drip, insulin drip. We want to help with potential ulcers by administering PPIs. We want to lower that pH. We want to replace fluids, right? We've lost potentially 6 liters of fluids from the pancreas autodigesting itself. And those fluids should be paired with electrolytes, right? Especially if we're administering large amounts of fluid, we're going to dilute and hemodilute our electrolytes even more. And then we want to keep the stomach pumped, so we can administer an NG tube to help limit how much work the GI tract has to do. And then anything with that boring pain, we can give morphine. That'll help with pain control. All right, so now we're into liver failure. Now, liver failure is typically caused, when we see it, by chronic alcohol abuse and acutely by a Tylenol overdose. So the patient may present with a mental status change. Remember, we talked about that ammonia being utilized by astrocytes, asterixis. So we can see them start to have these tremors, especially in their hands. And so that's again related to the brain swelling. We start to see the diencephalon start to have problems functioning. Ascites, a lot of that albumin and those proteins are low because we aren't able to form them as well with the liver. So a lot of that fluid, we have a lower oncotic pressure. So a lot of that fluid leaves the vascular space, and we start to see ascites in the abdomen. We talked about that jaundice with the inability to break down heme into bilirubin and conjugate it. That's the key, is conjugating our bilirubin. That's our total bilirubin. We can see an enlarged liver, and then it can potentially lead to sepsis. So a lot of this we gotta keep an eye on of what the patient's potentially presenting with. So they won't ask you necessarily the stages of hepatic encephalopathy, but what it tells you is how quickly that ammonia is rising. And again, that could be patient specific. Some patients may be much more susceptible to ammonia in their brain developing towards encephalopathy than someone else may be. So what are some things and what do we want to avoid with that causes an increase in ammonia? One of them is hypokalemia. So anytime potassium is low, it's going to trigger ammonia to be created within the kidney to help reabsorb that potassium. So what ends up happening is the kidney produces ammonia to then trade with potassium so that potassium is not lost in the urine. Anytime we have a high protein breakdown, right? We talked about that with blood. And anytime we're in a state of lactic acidosis, our liver is responsible for that lactate to be then converted back. So anytime we give Ringer's lactate, we're not able to reconvert that lactate and utilize it because we have a dysfunctional liver. And you can see that here. We ferment in the case of hypoxia as well. We start to ferment pyruvate into lactate, and then this function up here where we turn lactate back into pyruvate is controlled by the liver. So what are some things we can do for our liver failure patients? One of them is, if we're trying to treat ascites, is to avoid hypokalemia. So we're going to give potentially potassium-sparing diuretics, right? We want to do anything we can to prevent GI bleeding or treat GI bleeding to avoid that protein increase. And obviously we want to avoid any low blood pressure because it's going to force the body into a compensatory anaerobic respiration. In order to maintain an energy content in those cells, it's going to produce lactic acid. Then we really want to restrict any dietary proteins. So something that we're giving a lot of our patients are these healthy shots. They have 24 grams of protein, and typically we want just 1 gram per kilogram of body weight. So if someone, let's say, weighs 60, 70 kilograms, that's a third of their protein intake for the day, just from that one little bottle of healthy shot. So if your hospital uses any kind of protein supplement, try to avoid that in your liver patients if able. And then if we want to improve our patients' encephalopathy, we can give lactulose to bind with that ammonia. We can give neomycin as an antibiotic to destroy those ammonia-producing bacteria. And then sometimes, like we talked about, they'll do that transjugular intrahepatic portal system shunt, so that TIPS procedure to bypass the liver if it's significant enough. So when we look at a more acutely ill liver failure patient, specifically a Tylenol overdose, what we're looking at is the depletion of an enzyme's ability to break down Tylenol. So normally Tylenol is broken down by N-acetylcysteine, and it uses something called glutathione. And so what we can do in a Tylenol overdose is provide a precursor for that molecule that's used up. And that precursor is cysteine. So when we give acetylcysteine, I don't have it on another slide here, but what we're doing is providing a precursor for that, so then the body can continue to break down that Tylenol. All right, so splenic rupture. So any patient with a history of splenic rupture is assumed to have a reduced immune function. So they'll probably ask you a question on that. If you have a patient with a splenic rupture, what are we looking out for? And that's potentially avoiding any compromised immunological state. Something that you're going to see with the splenic rupture is a lot of deferred pain. This is just an image of showing where pain is deferred to. So you can see how the heart, it is deferred to the left arm. The spleen is a similar thing, left shoulder. And that's going to be known as the Kerr's sign. So the patient gets a blunt trauma to their left mid flank, and they have, but the way they present to you is with left extreme shoulder pain, and that's known as Kerr's sign. All right, and now we'll talk about intra-abdominal hypertension and how to treat compartment syndrome. So the things we have to know are the normals, or normal intra-abdominal pressure is between 0 and 5. And a high intra-abdominal pressure, or something that's known as intra-abdominal hypertension, is anything over than 12 millimeters of mercury. So the way we start to look at that is applying the equation of abdominal perfusion pressure, similar to cerebral perfusion pressure. It's MAP minus intra-abdominal pressure, just like cerebral perfusion pressure is MAP minus ICP. So if we know our normal MAP and we subtract our current intra-abdominal pressure, we would start to look at what our patient is presenting with. So anything over than 60 is associated with good outcomes, right? If your MAP is 65 and you have an intra-abdominal pressure of 5, then anything over 60 is good. Now, anything lower than that is associated with a lot higher mortality, especially anything that is sustained over 20. So any abdominal pressure over 20, despite what their perfusion pressure is very bad. And that's where we start to diagnose our patients with abdominal compartment syndrome, is when they have a high intra-abdominal pressure despite a normal perfusion pressure. So you may have seen this before, but you're going to place your patient in a reverse Trendelenburg position. You're going to try to sedate them, try to keep them comfortable. Placing them in that position is going to help take pressure off the abdomen. You're going to do a lot to manage their pain. Another thing we could do to help with intra-abdominal pressure is place the NG tube to low intermittent suction. Give Reglan to kind of clear out the abdominal system. And then if necessary, if it's very high for an extended period of time, they can do decompressive surgery and go in and figure out where this high pressure source is coming from. So you can pause the video here and kind of look at how this intra-abdominal monitoring system works. It's very similar to an ICP system. You're trying to look at the pressure within the bladder, which kind of tells you the pressure within the rest of the abdomen. All right, so that was GI. There are a few more sections like bowel infarction. So you have a clot that ends up cutting off some blood flow to your mesenteric arteries. You can also see questions on bowel obstruction or bowel perforation. There are also occasionally a question on TPN or tube feedings. And so just spend just a rough 30 minutes, 15 minutes on reading that content in your book. But just realize that they're going to quiz you more so on those bigger topics. So dedicate your time that you have saved before your exam to those content questions that you're most likely going to see. So we'll do a couple questions here. One of them being, your patient's admitted after an assault with a baseball bat. On skin assessment, you notice left flank bruising and receiving complaints of 7 out of 10 flank pain. What is the patient most likely to have? A. Retroperitoneal bleeding. B. Hemorrhagic pancreatitis. C. Splenic rupture. Or D. Large bowel perforation. Now, in this question, you hit that left flank, and they may give you a more specific question, maybe looking for splenic rupture. But they could throw in this word flank pain instead of left shoulder pain. And so that might throw you off to think they might be trying to do that to try to get you to think about deferred pain. So in this case, you would say that because you'd either probe further to see if they are having left shoulder deferred pain, and probably just say it's retroperitoneal bleeding because you only see bleeding on that left flank. So this is a more difficult question. A patient with hepatic encephalopathy is admitted from the ER, intubated, and severely hypovolemic. So far, labs have been obtained showing expected elevated liver enzymes, a high bilirubin, and a high ammonia level. The lactic acid is 4.1 and the potassium is 3.1. So what priority intervention do you suggest to the medical team? Would you start lactulose, neomycin, watch their vitals every 15 minutes, and give an lactated ringer bolus? Would you start medications to lower ammonia and begin a high-protein diet? Would you administer a PPI, avoid any oversedation, and give IV potassium? Or would you consult vascular or surgery for potential TIPS shunt, start vasopressors, and hold all sedation? So a lot of these interventions are good, right? We want to do lactulose. We want to administer PPIs. We want to hold sedation. Not all sedation because the patient is intubated. But we want to avoid oversedation. Definitely want to give potassium. So this, all the green here, shows all the good things we want to do, right? We don't want to give them lactated ringer bolus if possible, because their body has to work more to break that down. We don't really want to give them a lot of protein. We probably wouldn't do a tip shunt because we don't know the extent of their liver failure if they are a possible liver transplant candidate. And we really wouldn't want to hold all sedation either, right? And more so, instead of pressors, we want to correct fluid volume. So C would be your best choice here. Final question. The following complications are related to pathophysiology of acute pancreatitis, except for what? So we're thinking physiology of acute pancreatitis. Would it be hypercalcemia related to pancreatic autodigestion? Hyperglycemia related to beta cell injury? ARDS related to type 2 alveolar cell injury? Or left lung atelectasis related to left diaphragm lift? So when we think about pancreatitis, we think about all that digestive enzymes, all that water leaking out, right? We're going to damage those type 2 alveolar cells that make surfactant. We're going to have a high blood sugar because we have lost our ability to get insulin to the correct places. We have left lung atelectasis because our pancreas is more on that left side. But what we're going to see is actually hypocalcemia. So this is the correct idea, but wrong direction. Okay, now we'll go on to renal concepts. So like I said earlier, we're going to talk about renal basics, go over acute and chronic renal failure. And so what we're really going to look at is pre, intra, and post-renal failure. Again, it's similar to GI, only about 6% of your exams, so 10 questions, so probably 2 or 3 questions on each topic. So we'll go over some basics to renal physiology, and I won't talk about a lot of this because it's a good picture to really just pause and read rather than have been read to. So what I will mention is the afferent and efferent arterial because we're going to be talking about pre and intra and post-renal failure. So you have an afferent arteriole that starts the arterial system of glomerular filtration. And that is capable of dilating to allow more blood entrance into the glomerulus. And as that vessel exits, it's still an artery, it's still carrying arterial blood. It's known as the efferent arteriole. That's allowed to constrict to potentially increase the engorgement and pressure exerted on the glomerulus here. So that is what's this constriction and dilation balance is what's capable of changing the glomerular filtration rate. And you can see here these different names for the tubules. We've kind of gone over this in nursing school and it's been reiterated in the ICU. But it's good to just remind yourself of where certain electrolytes and where water is pulled and pushed into, just as a reminder. And on the left over here, I included these numbers match this image over here on the right. So you can see where these different diuretics act on different parts of these tubules. So just take some time to pause or take a picture of this to review later. Because they may not necessarily ask you a question about this, but it's good to know for your patients that you're taking care of where these drugs are working within their kidney. But some important lab values to know are BUN, right? We talked about that in GI, especially with liver. And we talked about how urea is the byproduct of protein metabolism. So therefore, it doesn't always indicate kidney function. It's not always a good indicator of how healthy or how efficient the kidney is working. But typically, we should see that between 10 and 23 milligrams per deciliter, right? We're always metabolizing proteins in our body. So we should always see some amount of ammonia being turned into urea. And then there's creatinine, a little bit different for males and females. But phosphocreatinine, a precursor creatinine, is found in muscle tissue and acts as a phosphate donator in order to make ATP. So that's what creatinine does. And so as that's used up, it has to be removed by the kidneys. And that rate of clearance is comparable to the filtration rate of the glomerulus. So that's why we look at creatinine a lot more when we're looking at kidney failure, is because the rate of clearing it is fairly equal to the rate of filtration by the glomerulus. Now, the glomerular filtration rate, how fast that blood flows through that little sac of arterioles, is about 125 milliliters per minute. And so when we think about how fast creatinine is cleared, we think of that inversely to GFR, right? If we have a higher GFR, then we would expect a lower creatinine clearance. We would expect more creatinine to have been cleared if our glomerular filtration rate is higher, right? If we're filtering more blood, we should be clearing more. Here's another way to look at it here. This is the formula. The big thing here is we're calculating weight and age and how creatinine clearance is calculated. So you're not going to necessarily need to know this for the exam of how to calculate that, but it's similar to how stroke index and cardiac index are calculated. Creatinine clearance is just more patient specific. So you can also measure the urine. So albumin in the urine should be pretty low, right? We shouldn't be getting rid of that much albumin in our urine. So we call that normally normoalbuminuria. So it should be less than 20 milligrams per day. And then anytime we see a little bit of albumin in the urine, more so than that 20, we call it microalbuminuria. And then when it's significant, we call it proteinuria, right? We're seeing lots of protein in the urine. Urine osmolarity, this one's a question, or these are values that you might see on the exam. So just be familiar with these. Creatinine clearance as well. You may see that on an exam. Some other big ones are urine-specific gravity. These are definitely questions that you'll probably, or values that you'll probably see worked into questions. And then all of your normal electrolytes there. So when we're talking about renal failure, we'll start with pre-renal failure. So pre-renal failure is any kind of failure caused by an issue before the kidney. So when we're thinking of that, we're thinking of a perfusion issue. So a hyperperfusion causing the kidney failure related to the glomerulus. So causes of poor glomerular perfusion, right? Anything that damages cardiac output, heart failure, MI, shock, any kind of tamponade or dysrhythmia, including a PE, any severe vasodilation, so in the form of sepsis or anaphylactic shock, and then any kind of volume depletion, anything that's going to prevent volume from even entering the glomerulus in the first place, like a hemorrhage or a GI loss. So just think about a lot of our initial presenting problems could lead to pre-renal failure. Some other things that can damage the kidneys are NSAIDs, because they block prostaglandins in the afferent arteriole, right? That's the first artery that enters the glomerulus. And so what's then going to end up happening is that's going to cause constriction of the afferent arteriole. So normally we like that to be nice and dilated to increase the amount of blood flow to the kidney, and NSAIDs could potentially constrict that and cause kidney damage. ACE inhibitors, they block angiotensin II, which is going to do the opposite in the efferent arteriole. It's going to, instead of causing constriction in the efferent arteriole, it's going to cause dilation. So it's not going to have a backup of pressure, right? We want a higher pressure in the glomerulus to allow it to then push more water and electrolytes across that border into the glomerulus. So by dilating that afferent arteriole, we're going to have more blood leaving the glomerulus faster and not being filtered. So big things with management is we want to restore any arterial blood volume in pre-renal failure. So we might need to focus on the heart in pre-renal failure, if that's the issue. And then we really want to be watching hourly intake and tracking that and making sure that we're not just doing this in the case of CRT or dialysis, but we're really monitoring how much our patient's putting in and taking out. Okay, then there's intrarenal failure. So this is more destruction of those tubulars, those tubular basement membranes that we saw in that first picture. So we may still have good perfusion to the kidneys. We may have no blockages on the outflow side of things, but what's causing the problem is now within the kidney itself. So any kind of nephrotoxic agents like dye or potentially antibiotics, NSAIDs, rhabdomyolysis. So a lot of these things can cause both pre and intrarenal failure. Now, these nephrotoxic causes, they're not as often oliguric. So the patient will still potentially be making urine themselves. But in a ischemic cause where we have a potential clot within the kidney, something that's preventing blood flow to the tissue itself of the kidney, not the glomerulus. So that would be in the case of pre-renal failure that's left too long. So we have hypoperfusion of the kidney for too long and those tissues start to die. That's when we start to see more oliguric, more a less potential to make urine at all. So dyes, antibiotics, rhabdomyolysis, we think recoverable. When we think of significant hypoperfusion to the kidney, we think less recoverable. So when we lose our ability to reabsorb these electrolytes, we start to see, and this is one we specifically look at, urine sodium. So you're going to get questions on the exam that's looking a lot at urine sodium. So since the kidney is very good at reabsorbing sodium, if we start to see that urine sodium at a very high level, then we know that these all these different filtering states within the nephron have been damaged. So what do we do to improve potentially intrarenal failure? Is we really want to promote the perfusion. We want to make sure that those nephrons are not dying and that we've already resolved pre-renal failure. Something we can do is kind of help coax the kidneys along is try to dialyze them early, so give them less to work with. So if we do a lot of the filtering before the blood reaches the kidneys, then that makes it less of an effort for them. And then we really want to try to oxygenate these kidneys, kind of really promote the tissues that have been damaged. And so we can give packed red blood cells or Epogen. Epogen is something that promotes the proliferation in order to increase red blood cell count. When we start to look at the differences between pre-renal, which is a risk for injury, versus intrarenal failure, which is actual injury, we got to start by looking at the labs. So one of the big things that we look at is this ratio of BUN to creatinine. And what we would expect is for creatinine to be 1 and BUN to be 20. So if the actual creatinine is 2, then we would expect the BUN to be 60. And so we simplify whatever that BUN creatinine ratio is, and we're looking for that number to be between, in a pre-renal failure, we would expect it to be between 20 and 40, that BUN, and the creatinine to be 1. Whereas at intrarenal failure, we would expect the BUN to be between 10 and 15, and for creatinine to be 1. And when we look at urine sodium, we would expect that to be a lot lower, right? Because even though the kidney isn't being perfused as well, it's still functional. So it's still able to retain that sodium within the actual body. So therefore, our sodium is lower, like it should be. Versus intrarenal failure, those nephrons have potentially died. So there's no reabsorption of sodium, so therefore it's higher. That's similar to the concentration of urine, right? The kidney's still functional, but there's less volume. So therefore, because there's less volume, it's more concentrated. Versus in intrarenal failure, we don't have that reabsorption of water. So any water that's introduced into the kidney is then lost straight out the nephron, not reabsorbed. Urine osmolarity, this should be higher for the same reason as the concentration. Same thing for specific gravity. And then the same is true for intrarenal failure, right? If we're dumping all of this water because we're not reabsorbing it, then the urine osmolarity should be low. Same for specific gravity. It's diluted. And if you remember back to that picture where Lasix activates within the kidney, we should see some sort of response from a still functioning pre-renal injured kidney versus an intrarenal injured kidney. We shouldn't expect a response because that nephron is potentially has died. So this is a practice BUN creatinine ratios. You'll probably see some of these on the exam. They might not ask you necessarily, is this an intrarenal or pre-renal injury? You might have to determine that yourself and then provide an appropriate intervention for that intra or pre-renal injury. So, for example, this first one, BUN of 90, creatinine of 2.8. An easy way you can do this is take 2.8, goes into 9 about 3 times, and then you can multiply that by 10. So 2.8 goes into 9 about 3 times 10 is roughly 30. So that's a pre-renal injury. You can do the same thing for this one down here, creatinine of 9.5. That goes into 9 about 1 time. Times 10 is 10. So this is probably an intrarenal injury. So you can go through all of these and determine if it's an intra or pre-renal injury. Go ahead, pause the video and figure out what those are, and then I'll flip the slide and show you the answers. So you can see intrarenal in red here, pre-renal in purple. Kind of the exact measurement of what that would be, but you get the idea of where it falls into place. They're not going to get it so close to this 20 like I did up here. They're going to give you more in the middle of the road or higher. Same thing for intra. They're not going to get it right on 15. They're probably going to do it as 10 or less. So just keep that in mind for when you're taking the exam. And then post-renal. This is a much more simple kind of renal failure. It's anything that obstructs the outflow of the urine, causing stress on the actual collecting ducts. So any kind of urethral blockage, like a stone, any kind of ureter blockage, like a stone, any kind of urethral blockage, like BPH or prostate cancer, a neurogenic bladder could cause backup, like in the case of MS or multiple sclerosis, or any kind of tumor that's causing retention of urine and eventual blockage of these collecting ducts. All right, so we'll do some clinical questions here to wrap up renal. Now, something important with these questions is to really pay attention to what the question's asking. So you have a patient with renal failure who has the following blood gas: 7.32 pH, that's acidotic, a CO2 of 35, that's normal, and a bicarb of 18. Okay, that would be expected with somebody in a metabolic acidosis. So this acid-base abnormality is the result of the kidney not excreting what? Acid byproducts from metabolism, the kidney not excreting CO2, the kidney not excreting bicarb, or the kidney not excreting calcium. So in a patient with metabolic acidosis, you would want the kidney to hold on to bicarb to try to correct this acidosis, correct? You would want to try to have a buffer. So the answer would be A. The kidney is not capable or is not despite compensating, must still be holding on to acid byproducts, which is driving that pH down. Right? We've identified that it's not a respiratory issue, that bicarb is able to compensate or partially compensate for the pH, but that there still must be a problem due to the kidney failure of not releasing acid byproducts that were created from metabolism. So what lab value do we use to best evaluate a patient's filtration rate? Do we use blood urea nitrogen, or BUN, creatinine clearance, or urine protein? So when we're trying to measure the filtration rate of the kidney, how fast blood's flowing through that glomerulus, what we really want to look at is the creatinine clearance, right? Because they're inversely related to GFR. So if GFR is high, then we would expect there to be a lower creatinine clearance. And BUN may be influenced by a lot of different things. So what we're going to do here is take an hourly long-term measurement of urine output. So like a 24-hour urine kind of thing. So a 35-year-old male developed an acute renal failure after an upper GI bleed secondary to esophageal varices, in which he lost a great deal of blood. Which of the following lab results would you expect? Would you expect a low urine osmolarity and high urine sodium? Would you expect a high urine osmolarity with high urine sodium? Low urine osmolarity with low urine sodium, or a high urine osmolarity with low urine sodium? So acute renal failure after a GI bleed. So the key thing we're thinking about in this question is, or hemorrhagic shock. We've lost a lot of blood. So what that's going to be is a pre-renal failure. And any kind of early pre-renal failure, we know that the basement membrane, those nephrons, are probably still functional and still able to remove sodium from the urine. So that urine will still be concentrated despite that lack of volume. So D. So we're going to have a high urine concentration, but a low urine sodium, right? The kidney's still functional. The kidney's still capable of retaining that sodium back into the body. So the only reason it's concentrated is because we have a lack of volume. So some other things to look for with renal failure and the renal section of the CCRN are your electrolyte abnormalities. So you'll learn a lot about this with cardiac as well as dialysis. Spend a little bit of time on dialysis, knowing what it's used for and in which kind of patients. And sometimes they'll ask questions about contrast medium nephropathy. So that's renal failure caused by contrast dye. And then rhabdo and how that can impact kidney failure, as well as what kind of electrolytes and what kind of lab values you're looking for. So I'd say spend about 2 hours on these topics just to familiarize yourself beforehand. They might not be big topics and therefore have few, if any, questions on the exam, but just having a base knowledge of that will help just in case you are given a question on them. So hope you enjoyed this one. Check out the respiratory and exam review and the hematology and hemodynamics review. Those kind of play into this one a little bit. So hope you have a good day, and we'll see you in the next review.